Good morning. Welcome to our weekly podcast on the latest advances in the field of oncology. I am Dr. Suryaprakash Vankina, consultant radiation oncologist, Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. Today we will be discussing about the Keynote A18 trial regarding the advances or latest treatment for cervical cancer. Today we have Dr. Kennothe Pathko, HOD and Clinical Director Radiation Oncology, Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, to discuss about this trial. Good morning, Dr. Kennothe Pathko.
Hi, Dr. Suryaprakash.
Can you give some insights on this clinical trial which was published last month? The Keynote A18 trial is published in the Lancet Journal in October 2024.
So, Keynote A18 trial on the cancer cervix, published in the Lancet October 2024, about the adding pembrolizumab to conventional CTRT standard arm, whether there is a benefit or not. So this study mainly done at Pimantias Hospital, Milan, and it is around 276 centers from the mostly from the Europe and some Asian countries and American countries, and they studied the adding pembrolizumab, is there any benefit or not.
Okay. Can you discuss what is the methodology adopted in this trial? What is the study protocol?
So it is a double-blinded phase 3 trial. They in this study there are two arms. In one arm, normal standard arm like concurrent chemoradiation therapy followed by brachytherapy in CS cervix. In other arm, they concurrent chemoradiotherapy with concurrent pembrolizumab followed by adjuvant pembrolizumab. In which parts of cancer cervix, stages of cancer cervix, mostly the early cancer cervix with nodal positivity and stage 3, stage 4.
So, as per the new FIGO staging, there will be stage 3C or stage 4?
Mostly advanced, because it is based on the 2014 staging.
Okay. If you adapt it to the newer staging, it's all stage 3C1 or C2 or stage 4. So, advanced cancer.
Advanced.
Okay. So, how many cycles of pembrolizumab was given in this?
So, if you see, there are mostly 1,000 patients enrolled, roughly 500 odd patients in each arm. They be given concurrent chemoradiotherapy in both arms, plus pembrolizumab as a concurrent for 200 mg per meter square every 3 weeks for 5 cycles, followed by 400 mg every 6 weeks for 15 cycles in experimental arm. In a standard arm, normal CTRT, brachy plus placebo. So these are the two arms, and 500 odd patients in the both arms.
So you mean to say the total treatment duration, the pembro arm, is around 96 weeks.
96 weeks. So the problem is here. Normal CTRT arm takes 2 months, roughly 8 weeks you have to complete the treatment. But in the pembro arm, it is 96 weeks, roughly 2 years.
2 years.
So 2 years versus 2 months.
Okay. So what are the endpoints of the study? What are the?
So primary endpoints are overall survival and progression-free survival. If you see, there is a significant improvement in overall survival around 8% and progression in survival in the 12%. 3-year overall survival and progression-free survival of median follow-up of 29 months.
So, what are the takeaway points from this clinical trial?
So, if you see their clinical trial, all these analysis, there is a difference in survival, overall survival, 3-year overall survival and progression-free survival arm in experimental arm. And if you see the more adverse events, immunotherapy related adverse events, hypothyroidism and hyperthyroidism, 39% in the experimental arm. It is quite double in comparing to the CTRT arm. And second thing is median follow-up is only 30 months, which is not a good follow-up data for the CA cervix patients. If you see the criticism, mostly the CA cervix, cancer cervix is a poor woman's disease. We are happy with treating 2 months of treatment, and even in Indian setting, if you see, the lots of people are not able to complete the treatment. You have to run behind them and convince them to take the treatment.
Yes.
But if you add pembrolizumab, you continue the treatment of 2 months to 2 years, so lots of disappearance will come. And pembrolizumab, you see the 15 cycles of 400 milligram and 5 weeks cycles of 200 milligram. It cost huge. What it is? So a poor family cannot.
Yes. I think one cycle of pembro costs around 2 lakh rupees.
So if you see all this, that, and the second thing is, so if you see the criticism, there are 10 criticisms I have found out. No Indian population, mostly Europe, American people, standard people, and some Asian countries, they have been enrolled. Cost is the issue. Longer duration of treatment, pharma funded, and if you see, out of 5,000 patients enrolled in 500 in each arm, or in each arm, half of the patient discontinued, and 200 odd patient in pembro arm and 200 patient in the
Standard
arm, they were discontinued, and it is mostly pharma funded. And if you see, in the subset analysis, those receiving 70 gram more to the HRCTV, they have a advantage. So if you see below 70 gram, it is not, there is no advantage. So if you see all these issues, so directly you can tell that more radiation dose is beneficial, which we know better. So it is getting biased by the adding pembrolizumab.
Yes.
And so standard, so we should not take it as granted the pembrolizumab should be added or in this juncture. So I feel pembro should be kept for those are metastatic disease, recurrent disease, where we cannot do there is no good option of radiation chemotherapy. But we should not change our policy. As a radiation oncologist or a oncologist fraternity, they should not change the policy to adding immunotherapy nowadays, decreasing the radiation dose. So we should go with the proper radiation dose within 2 months. Our aim should be patient should complete radiation within 2 months, 60 days treatment, or 50-60 to 60 days treatment. Proper CTRTR, unnecessary, we should not add toxicities of immuno-related things of a huge cost burden to the patient. So in my view, we should not jump directly to immunotherapy arm. And if you see the same trial like a Kala trial, which is funded by the AstraZeneca Durvalamab study, that is also not much benefit in comparison. One other immunotherapy is not benefited, and this so there is some discrepancy and more very few months of median follow-up. We should not take as a granted that immunotherapy gives a benefit in this cancer.
You mean to say that we have to wait for a longer follow-up data?
Longer follow-up data. Cost. Now we should give AMT, complete the CTRT properly within 60 days. That proper radiation dose to the HRCTV, that should be our aim. Our aim should not be in the adding pembrolizumab at this juncture.
Okay. So in our last podcast, we discussed regarding the interlace trial where neoadjuvant chemotherapy with paclitaxel, and again there is another trial where immunotherapy. So is the treatment of cervix cancer moving away from radiation oncologists?
See, some trials, interlace trial, there is some bias chemotherapies, bias immunotherapies, we should not worry about it. First, our aim is to complete the radiation chemotherapy as a standard. We should not underdose the radiation dose, should not prolong the treatment arm. So that should be our aim. We should not get biased by putting NSCT or adding the adjuvant chemo or adjuvant immune. So as a not am a radiation oncologist, as a oncologist, as a doctor, I can tell, please don't get biased. But some specific group of people, residual disease after chemotherapy arm, metastatic disease, recurrent disease, and those are the things, big parabolic nodes we cannot do with radiation CTRTM directly. They can receive the NSCTRP, then after degradation we can go ahead. These things I can adopt, give some NSCT or adjuvant pharmacotherapy immunochemo, that is okay for me. But without any indication of adding new adjuvant chemotherapy or adding immunotherapy is not at this juncture. Please consider radiation is the standard, chemoradiation is the standard, proper brachytherapy, at least dose of 80 to 85 gray, complete the 5 cycle of cisplatin concurrent chemo arm, proper radiation dose. That will be more attractive than adding immunotherapy and chemotherapy.
Yeah, probably doing good brachytherapy with image guidance.
Image guidance. That will be the more. We should more the radiation oncologist should go ahead with proper brachytherapy practice and dose, adequate dose. There is in the subset analysis of some people less than 70 gray. Why we should give less than 70 gray to a
carcinoma cervix?
Carcinoma cervix. So decreasing radiation dose, increasing the cost, increasing the so if you see the Keynote trial, patient has to run behind the hospital around 2 years.
Yes.
People are not coming for 1 year to 1 month, 2 months, and you are asking the patient 2 years. When a patient comes to you, will tell, 2 years treatment, and somebody will do 2 months. So I am not in the favor of adding immunotherapy in this juncture.
Okay. Thank you, Dr. Patrov, for your inputs on the Keynote A18, right? Let's meet next week on other latest advances in the field of oncology.
Thank you, Dr. Suryaprakash. Thank you.